Welcome to the Deep Dive, where we cut through the noise to get you well-informed, fast. Today we're plunging into a topic that touches countless lives, often in ways that are truly debilitating. Headaches. And we're talking about so much more than just, a typical headache. These are conditions that can genuinely derail a person's life. For this deep dive, we've pulled from some pretty heavyweight sources. We've got a comprehensive clinical guideline from NICE, that's the National Institute for Health and Care Excellence, specifically on headache diagnosis and management for individuals over 12. And we're pairing that with global recommendations from the International Headache Society, or IHS, which offers crucial insights into acute migraine treatment.
Right. And our mission today, really, is to distill the most critical knowledge from these key sources. Think of this as your personal shortcut to understanding exactly how different types of headaches are identified, what their unique characteristics are, and, crucially, the best ways to manage them. It's all tailored for you, the curious learner. The ultimate goal is to improve recognition and management and, well, frankly, significantly enhance the quality of life for people affected by this.
Yeah, absolutely. And trust me, we've got some powerful insights and really practical takeaways that can empower you, whether you experience headaches yourself or you care about someone who does. We're moving beyond just treating symptoms, aiming for that full picture of headache care. So let's start by acknowledging just how widespread the impact of headaches truly is. I mean, they are, without a doubt, one of the most common neurological problems people see doctors for.
Oh, absolutely.
And for individuals, they're not just a nuisance, are they? They're incredibly painful, debilitating, a huge cause of missed work or school, and honestly, a substantial burden on society.
That's spot on. And when we talk about headaches, it's really vital to differentiate between two main categories. You've got what we call primary headaches. Think migraine, tension-type headache, cluster headache. In these cases, the headache is the condition itself.
Right.
Then there are secondary headaches, which are actually symptoms of something else going on underneath. A really common one is medication overuse headache. So our focus today will be on these most common primary types and also on medication overuse headache, which, as you can imagine, often develops from trying to treat a primary headache in the first place.
Okay, and that really underscores why getting an accurate diagnosis is so important, doesn't it?
Mm-hmm.
It means you can get much more targeted treatment, and it probably reduces the need for loads of unnecessary tests, too, which must be a relief.
Precisely. For anyone experiencing a headache, there are specific red flag symptoms. These tell us something potentially serious might be going on, needing immediate attention, investigation, or referral. Knowing these can be crucial, potentially even life-saving. It guides your next steps.
Okay, like what sort of things are we talking about?
Well, for instance, a worsening headache that comes with a fever, or a sudden onset headache reaching its maximum intensity within 5 minutes. We sometimes call that a thunderclap headache.
Wow.
Other red flags include any new neurological deficit or, say, cognitive changes, a shift in personality, impaired consciousness, also recent head trauma within the last 3 months, or maybe a headache triggered by coughing, straining, like lifting something heavy, sneezing, or even exercise.
Okay.
An orthostatic headache, one that changes when you change posture, especially standing up, that's another one. Symptoms suggesting giant cell arteritis or acute narrow angle glaucoma, too. And really importantly, any significant change in the pattern or characteristics of a headache you already have, that always needs looking into.
So it's really about knowing when to be properly concerned versus when it might be, a typical, though still awful headache.
Exactly. And beyond those immediate flags, there are other situations needing investigation or referral. Maybe a new headache in someone with compromised immunity, perhaps due to HIV or certain drugs, or in individuals under 20 with a history of cancer, or anyone with a cancer known to spread to the brain, and persistent vomiting without any other obvious cause.
Got it. Now, one simple yet incredibly powerful tool that both sources highlight is a headache diary. You mentioned it briefly. It sounds almost like being a detective for your own head, right? Tracking clues.
That's a fantastic analogy. Yeah, a headache diary can be invaluable. If you use one, you should track several key things for ideally a minimum of 8 weeks. This includes how often they happen, how long they last, how severe they are, any associated symptoms. Also, all medications you take for them prescribed and over the counter. It's also really useful to note possible triggers or precipitants, and for women, the relationship of the headaches to menstruation. It helps your doctor see patterns they might otherwise miss.
Okay, so once we're tracking things, how do healthcare professionals actually tell the difference between the most common primary headaches? Because let's face it, to most people, they can all just feel like a bad headache. What are the key distinctions for tension type, migraine, and cluster headaches?
It really comes down to comparing their unique features carefully. Let's start with tension-type headaches. Okay.
Mhm.
The pain here is usually on both sides of the head bilateral. The quality, often described as pressing or tightening, non-pulsating. Intensity is typically mild or moderate. Crucially, it's generally not made worse by routine activities, and you don't usually get other major symptoms like light sensitivity.
Okay.
Duration can be anything from 30 minutes up to continuous. We call them episodic if they're on fewer than 15 days a month, or chronic if it's 15 or more days a month for over 3 months. Now, migraines. These can be unilateral, one-sided, or bilateral. The pain quality is often pulsating or throbbing, particularly in younger people, and it's usually moderate to severe.
Right, that sounds different already.
Yeah, and migraines are typically aggravated by routine activities, or they make you want to avoid them altogether. You just want to lie down in a dark, quiet room.
Totally.
They also often come with sensitivity to light and a sore sound, or nausea, sometimes vomiting. Aura symptoms can also happen. We can talk more about aura in a sec. An attack typically lasts 4 to 72 hours in adults, like tension headaches. They can be episodic or chronic. And here's something interesting. Chronic migraine and chronic tension-type headache often overlap. But if any migraine features are present, the diagnosis should be chronic migraine. Migraine symptoms kind of trump tension-type ones if both are chronic.
Ah, that's a key diagnostic point. Okay, and the third one, cluster headaches.
Cluster headaches, these are distinct and often described as excruciating, really severe. The pain is strictly unilateral, always one side, typically around the eye, above it, or along the side of the head or face. The pain quality varies, sharp, boring, burning, throbbing, tightening, but it's consistently severe or very severe. And instead of wanting to lie still, people often feel restless or agitated during an attack. They can't sit still. These also come with specific symptoms on the same side as the pain. Things like a red or watery eye, stuffy or runny nose, maybe a swollen eyelid, facial sweating, or even a constricted pupil or drooping eyelid.
Very specific signs then.
Very specific. And the duration is much shorter, usually 15 to 180 minutes, but the frequency can be whirled anywhere from once every other day up to 8 times a day during a cluster period.
That level of diagnostic detail is really insightful. It's so precise.
Yeah.
Now, you mentioned aura with migraine. What exactly is aura, and are there different kinds?
Good question. So migraine with aura involves neurological symptoms that are fully reversible. They typically develop gradually over, say, 5 minutes or more, and usually last between 5 and 60 minutes. The most common types are visual, like seeing flickering lights, spots, lines, or maybe losing part of your vision temporarily. But aura can also be sensory, like numbness or pins and needles, or involve speech disturbances. Now, it's really important to note, certain atypical aura symptoms need further investigation. Things like motor weakness, double vision, visual symptoms affecting only one eye, poor balance, or a decreased level of consciousness. If you experience those, definitely get it checked out.
Right, important distinction.
Then we have menstrual-related migraine. You'd suspect this type if your migraines happen mostly between 2 days before and 3 days after your period starts, and this pattern recurs in at least 2 out of 3 consecutive cycles. And to confirm this, that headache diary we talked about is really helpful, tracking things for at least 2 menstrual cycles.
Okay, so connecting all this,
Yeah.
let's talk about one of the trickiest problems in headache care. Medication overuse headache, or MOH. It seems so counterintuitive, doesn't it? That the medicine you take for pain could actually cause more pain.
It is counterintuitive, but it's a critical insight. Being alert to MOH is vital. You should suspect it if someone's headache developed or got worse while they were taking certain drugs frequently for 3 months or more.
Which drugs are we talking about?
This includes triptans, opioids, ergots, those older migraine drugs or combination pain relievers taken on 10 or more days per month, or even common things like paracetamol, aspirin, or NSAIDs taken alone or mixed if they're used on 15 or more days per month.
Wow, even standard painkillers.
Yes, it's a major concern because these are often the very drugs people take for their primary headaches, like migraine or tension type. It creates this really difficult cycle where treating the headache actually causes more headache.
A vicious cycle indeed. So, thinking about managing all these headache disorders, what are the general guiding principles?
Okay, some key principles apply across the board. First, it's absolutely vital to involve the person in decisions about their own care, shared decision-making. Second, providing a positive diagnosis, explaining it clearly, and offering reassurance that other serious causes have been ruled out. That's essential.
Makes sense.
Giving both written and verbal information about their specific condition and maybe pointing them towards relevant support organizations is also really helpful. And critically, neuroimaging, like an MRI or CT scan, shouldn't be done just for reassurance. It needs a solid clinical reason.
Okay.
Lastly, and this is so important, always explain the risk of medication overuse headache to anyone who's using acute headache treatments frequently. Awareness is key.
That's a powerful point about patient involvement and clear communication.
Yeah.
Okay, let's dive into the specific treatments. What does the approach look like for tension-type headache?
Right. For acute treatment of tension-type headache, common over-the-counter options like aspirin, paracetamol, or an NSAID can be considered. You know, always thinking about the person's preferences, other health conditions, and risk of side effects. A very important note here. Aspirin shouldn't be offered to anyone under 16 because of the risk of Ray's syndrome.
Good safety point.
And a definite don't. Opioids should absolutely not be offered for acute tension-type headache.
Okay, clear no-go there.
Yeah.
What about prevention if it's chronic?
For prophylactic or preventative treatment of chronic tension-type headache, a course of acupuncture might be considered, usually up to 10 sessions over about 5 to 8 weeks.
Interesting. Now on to migraine, with or without aura. This seems like where the treatment options really branch out, probably because migraine can be so complex and debilitating.
Exactly. For acute migraine treatment, the initial thinking often involves combination therapy. So maybe an oral triptan that's a specific type of drug designed to stop a migraine attack combined with an NSAID. Or alternatively, an oral triptan combined with paracetamol. For younger people, say 12 to 17, nasal triptans are often preferred over pills.
Okay.
Now, if someone prefers to take just one drug monotherapy, options include an oral triptan, an NSAID, aspirin at a 900 milligram dose, or paracetamol, again, remembering no aspirin for under 16s. When prescribing a triptan, it's usually recommended to start with the lowest cost one. If that doesn't consistently work, you should try one or more alternatives because people respond differently to different triptans.
Right. Trial and error sometimes.
And an antiemetic that's an anti-sickness medication should also be considered. Even if the person isn't feeling nauseous, it can sometimes help the other medications work better. Now, if oral or nasal options don't work well or aren't tolerated, you might look at non-oral preparations, things like metoclopramide or prochlorperazine injections. Sometimes adding a non-oral NSAID or triptan might be considered then.
Okay.
And there's a newer, quite interesting option for acute migraine in adults, rimegepant. It's an oral CGRP inhibitor. This is generally recommended if someone's tried at least 2 different triptans and they didn't work well enough, or if triptans are contraindicated or weren't tolerated, and NSAIDs and paracetamol also weren't sufficient.
So a newer line of defense. What about things to absolutely avoid for acute migraine?
2 crucial ones to steer clear of for acute migraine treatment are ergots, those older drugs I mentioned, and opioids. Definitely not recommended.
Got it. And what about preventing migraines from happening in the first place? Prophylactic treatment.
Right, prevention. This involves a discussion about the benefits and risks of different options. Common first-line choices include drugs like propranolol, topiramate, or amitriptyline. It's worth noting, for topiramate, there's specific guidance from the MHRA, the UK's medicines regulator, regarding its use in women who could become pregnant due to potential risks. It requires adherence to a pregnancy prevention program.
Important safety information there.
Absolutely. If the first preventive treatment doesn't work or isn't tolerated, then you discuss trying a second and potentially a third option from that group. One drug to specifically avoid offering for migraine prophylaxis is gabapentin.
Okay.
If these first-line preventives haven't worked or aren't suitable, then acupuncture again, up to 10 sessions over 5 to 8 weeks can be considered. Also, the supplement riboflavin vitamin B2 at a dose of 400 milligrams once a day may be effective for some people in reducing migraine frequency and intensity. Worth discussing.
And what about those newer CGRP inhibitors? Are they used for prevention too?
Yes, exactly. This class of medications targets a specific pathway involved in migraine pain. They offer new hope for many who haven't found relief with older preventatives. These include drugs like atogepant, which is oral, and injectables like eptinezumab, fremanezumab, erinumab, and galcanezumab. These are generally recommended for adults who have frequent migraines, defined as at least 4 migraine days a month if at least 3 previous standard preventive medicines have failed or weren't suitable.
So it's for more difficult cases?
Generally, yes. Another option for prevention, specifically for chronic migraine in adults, is botulinum toxin type A injections. But again, this is typically reserved for cases where at least 3 other preventative medicines have failed, and if medication overuse headache is present, it needs to be properly managed first. And with all these preventatives, you need to review whether they're still needed, usually about 3 to 6 months after starting. There are also specific criteria for stopping the CGRP inhibitors, like if there isn't a significant reduction in migraine days after 12 weeks. Same for botulinum toxin if it's not providing enough benefit after 2 cycles, or if the migraine becomes less frequent.
Right. Regular reviews are key.
Yeah.
What about those special migraine subtypes you mentioned?
Yeah.
Menstrual migraine or migraine with aura and contraceptives.
Good points. For women and girls who experience migraine with aura, combined hormonal contraceptives, the standard pill should generally not be routinely offered for contraception due to a slightly increased stroke risk.
Okay, that's important.
For predictable menstrual-related migraine, if it doesn't respond well to standard acute treatments, you might consider using a triptan like frovatriptan or zolmitriptan, specifically on the days you expect the migraine to occur, as a sort of mini prevention. And if migraine treatment is needed during pregnancy, paracetamol is considered the first line for acute attacks. Triptans or NSAIDs can be considered, but only after a thorough discussion of the risks. For preventive treatment during pregnancy, it's best to seek specialist advice.
Okay, super helpful specifics there. Let's switch gears to cluster headache. You described these as excruciating. What's the approach here?
Yeah, they really can be. For someone having their first bout of cluster headache, discussing the need for neuroimaging, like an MRI with a headache specialist is usually recommended, just to rule out other causes. For acute treatment stopping an attack once it starts, the 2 main options are oxygen and triptans.
Oxygen.
Yes, high-flow oxygen, specifically 100% oxygen delivered at a rate of at least 12 liters per minute through a non-rebreathing mask with a reservoir bag. It can be remarkably effective for many people. Arrangements should be made for them to have this available at home and maybe even portable supply. The other main option is a triptan, but specifically subcutaneous injection or a nasal spray because they work much faster than pills, which is crucial for a cluster headache.
Makes sense, given how quickly they come on. What should be avoided?
Right. For acute cluster headache treatment, you should not offer paracetamol, NSAIDs, opioids, ergots, or oral triptans. They're generally ineffective or too slow.
Okay. And prevention during a cluster bout.
For prophylactic treatment during a cluster period, the drug verapamil is often considered first line. However, specialist advice is always recommended before starting it, as it requires careful dosing and monitoring, including ECGs to check the heart. And specialist advice is also definitely needed if the cluster headache doesn't respond to verapamil or if treatment is needed during pregnancy.
All right, specialist input seems key for cluster headache. Finally, let's circle back to medication overuse headache, MOH. We know how it happens. How do you treat it once it's identified?
Okay, MOH treatment. The absolute cornerstone is stopping the medication that's being overused. People need to be advised to stop all the acute headache medications they've been overusing for at least 1 month. And the advice is usually to stop abruptly rather than trying to taper down gradually.
That sounds tough. What should people expect?
It is tough. It's really crucial to prepare them that their headache symptoms are likely to get worse in the short term. They might also experience withdrawal symptoms depending on the drug. Because of this, close follow-up and lots of support during this withdrawal period are absolutely vital. Alongside the withdrawal, you might also consider starting or adjusting prophylactic treatment for their underlying primary headache disorder, like migraine. Generally, people don't need to be admitted to hospital for withdrawal unless, perhaps, they're overusing strong opioids, have significant other health problems, or have tried and failed withdrawal several times before. After about 4 to 8 weeks from starting the withdrawal, the diagnosis and the overall management plan should be reviewed.
That withdrawal phase sounds challenging but necessary. Okay, this is where the personal curation really shines through for our listener. Let's talk about optimizing treatment for individuals. Timing, for instance. Does it really matter when you take acute migraine medication?
Timing is absolutely critical for effectiveness, yes. For migraine without aura, the advice is generally to take the treatment when the pain is still mild, as early as possible in the headache phase. For migraine with aura, you should usually wait for the aura symptoms to subside and take the treatment as soon as the headache phase actually starts. Why? Well, Early treatment is more effective because it hits the headache before something called central sensitization really kicks in. That's when the nervous system becomes sort of hypersensitive to pain, making the whole thing harder to stop.
Right, nip it in the bud.
Exactly. And interestingly, triptans, while great for the headache pain, don't really work on the aura symptoms themselves. That's a different process in the brain. The newer drugs, the diazepams, are a bit unique here. There's some evidence they might even be effective if taken during the prodrome, that phase before the pain starts for some people. And a big plus, they don't seem to carry that risk of medication overuse headache.
That's a significant advantage. What about those really challenging symptoms, like someone who experiences early vomiting during an attack? Taking pills must be almost impossible.
You're absolutely right, it is. For people who vomit early in a migraine attack, non-oral formulations are highly recommended. We're talking subcutaneous injections, maybe intranasal sprays, or even suppositories. Orally disintegrating tablets, which dissolve on the tongue, can also be an option.
Okay.
Alternatively, you could suggest combining their usual painkiller, like a simple analgesic, NSAID or triptan, with an antiemetic and anti-sickness drug taken right at the start.
Got it. What about pregnancy and breastfeeding? Huge area of concern for many.
Yes, very important. During pregnancy, if things like rest and hydration aren't enough, paracetamol or acetaminophen is generally considered the first choice. Triptans can also be used, but with caution across all trimesters after discussing risks. Metoclopramide can be added for nausea or if pain relief isn't enough. While breastfeeding, paracetamol acetaminophen is again the preferred choice. Some other drugs like diclofenac, naproxen, triptans, and gepants can potentially be used cautiously, perhaps advising the mother to withhold breastfeeding for about 8 to 12 hours after taking the dose, though individual advice is key. What should definitely be avoided during both pregnancy and breastfeeding are those combination painkillers that contain butylbetal or opioids.
Okay, clear guidance there. And for the children and adolescents, say 12 and up.
Right, for this age group, 12 plus. The first-line acute treatment for migraine attacks is usually paracetamol acetaminophen, dosed according to their weight, or ibuprofen, also dosed by weight. If those aren't effective enough for adolescents, then triptans can be used as a second-line option. Rizatriptan, with dose based on weight, or sumatriptan nasal spray are often preferred because they have the most study data in this age group. Metoclopramide can also be added if there's nausea or vomiting, or if the attacks are particularly disabling.
Good to know the options for younger people. What about at the other end of the spectrum, people over 65?
For older adults, assuming normal liver function, paracetamol acetaminophen is generally suggested as the first-line therapy, though it might be wise to suggest keeping the total daily dose a bit lower, say under 3,000 milligrams. Combinations containing caffeine can be used, but with caution, because you need to be mindful of overuse and potential withdrawal headaches from the caffeine itself. As a second-line option, aspirin and NSAIDs can be used, but they require closer monitoring in older adults due to the increased risk of side effects like gastrointestinal bleeding or kidney and liver problems.
And triptans, are they generally okay for older adults?
That's a really common question. Triptans can be considered as a third-line treatment, but only if the person doesn't have uncontrolled high blood pressure or any serious heart or cerebrovascular disease. And this is where those newer options, lasmiditan and the gepants, become particularly useful alternatives, especially for older adults who might have contraindications to triptans, because these newer drugs don't cause vasoconstriction. They don't narrow blood vessels, which is often the main concern with triptans in this age group.
That's a key difference.
It is, though it's important to advise people about potential central side effects with lasmiditan, like dizziness, which could increase the risk of falls.
Okay. What about people with a history of stroke, other vascular diseases, or uncontrolled high blood pressure? That must require careful consideration.
Extremely careful consideration, yes. For acute migraine treatment in this group, paracetamol is definitely first line. Lasmiditan or agepants are excellent second-line choices here precisely because they lack those vasoconstrictive effects.
What's that safety profile again?
Exactly. NSAIDs can be used, but their use should probably be limited, especially if the person is also taking blood thinners due to the increased bleeding risk and the potential for NSAIDs to increase blood pressure. Adding an antiemetic can be helpful too, triptans. Well, they can be used cautiously if these conditions are well controlled and other options haven't worked, despite the historical concerns. But it requires careful judgment. However, dihydroergotamine, DHE, and ergotamine, those older vasoconstrictors should be avoided completely at all times in these individuals. The risk of serious ischemic complications is just too high.
Okay, very clear boundaries there. What about when a headache comes back soon after treatment seemed to work? That frustrating headache relapse. What's the plan?
Yeah, relapse is common. If a headache comes back within, say, 48 hours after it was initially treated successfully, taking a second dose of the same medication is usually okay as long as you stay within the recommended daily limit. If that second dose isn't effective, then it's probably best to switch to a different drug, maybe from a different class entirely for that recurrence.
And if it happens often?
If early headache relapse happens with most attacks, then you should probably consider switching to a different acute treatment option altogether for future attacks. Or another strategy is to combine a triptan with an NSAID from the start of the attack. Just remember, if you use a combination treatment, you generally need to wait at least 2 hours from the first dose before repeating it.
Okay. And what about that really severe, prolonged status migrainosus? Migraine lasting over 72 hours?
Right, status migrainosus. It's tough because reliable evidence on the best treatment is actually quite scarce. But common approaches often involve non-oral treatments like intramuscular NSAIDs, subcutaneous sumatriptan, or sometimes oral or nasal DHE combined with antiemetics. In an emergency room setting, intravenous NSAIDs or aspirin are often used, sometimes along with antidopaminergic drugs like prochlorperazine or metoclopramide, which help with nausea and might have other beneficial effects. If those don't work, other options that might be considered include steroids, peripheral nerve blocks, intravenous magnesium, or sodium valproate.
What about opioids in that situation?
Crucially, opioids should be avoided at all times for status migrainosus, just not the right approach.
Got it. Finally, and this loops back to preventing MOH, can you remind us about the maximum recommended days per month for using acute medications?
Yes, this is a vital piece of practical advice. To minimize the risk of medication overuse headache, it's generally suggested to limit the use of simple analgesics like paracetamol, NSAIDs, or lasmiditan to maybe 2 to 3 days per week, and definitely less than 10 days per month in total.
Okay, less than 10 days a month for those.
Right. And for combination analgesics, those pills with multiple ingredients, and for triptans, the limit is even stricter. Try to use them on no more than 2 days per week and less than 8 days per month total.
Less than 8 for triptans and combos.
Exactly. And it's really worth reiterating here that the G-depans, both for acute and preventative use, have not been associated with causing medication overuse headache. So that makes them a potentially preferred choice for people who find they need to use acute medication quite frequently as they don't carry that specific MOH risk.
That's a massive takeaway. Wow, that was a truly comprehensive deep dive into the incredibly complex world of headaches. We've unpacked so many critical insights from these leading guidelines, everything from how to distinguish different headache types to navigating all the acute and preventative treatments across different life stages and health conditions. I feel like you, our listener, are now equipped with so much more than just surface-level info.
Absolutely. Our exploration today really highlights how crucial tailored approaches are. Careful diagnosis, understanding all these nuances of medication, it really can significantly improve the lives of people impacted by headaches. It's definitely about finding the right tools for the right person and the right headache.
Definitely. So, thinking about everything we've covered, what further mysteries of headache do you think we should maybe explore next time? I'm thinking perhaps the role of psychological interventions like CBT, or maybe digging deeper into the ongoing research into even newer preventive treatments. The journey to being well-informed about health is definitely an ongoing one, isn't it? And we feel like we're just getting started.